Okay. Hello, everybody, and welcome to week 3 of the Winter Endurance Sports Medicine lecture series. We're super excited. We've got some awesome people coming to speak. We've got Robin McKeever, the head coach of ParaNordic Olympian, and he's an Olympian, Paralympian. He's going to be talking about the challenges of preparing for Winter Paralympics 2022. Then we got the super esteemed Dr. Andy Reid, who's going to speak about cardiorespiratory considerations in cold weather training. And then coming up at the end, we've got Dr. Patrick Fredette, who's going to be speaking about hypothermia and frostbite. So an action-packed power play, whatever you want to call it, night with Chasm and our good friends here. We'd like to thank our sponsors and our speakers, MD Financial Management, Nordic Canada, Pendo Farm, BAM Sports Medicine. Just a couple of things. The video recordings are available, and the link to the playlist is in the follow-up emails. Helen's going to put it in the chat as well, but you'll get an email with the link on YouTube, and the first 2 weeks will be on there as well. And then there's some additional bonus material in there as well that you will be able to access. If you have any questions, please look at the bottom of your screen, somewhere around there, and there's a button that says Q&A. And if you click on that button, then you can go in there and type in your questions, and I'll go through them and ask them to the presenters at the end of it all. And if you have any questions in there and they don't get answered because we need to move on to the next presentation, we will be sending them to the speakers and we will get replies to all of you. Additionally, you can email Helen, and Helen's going to put her email in the chat if you have any further questions after the evening's all done. Like I said, the recordings will be available to you tomorrow, and the link for next week's session will be sent to everybody tonight. So some brand new, super amazing news. The digital host with the most, myself, and we got Dr. Lee Schofield and Dr. Janet McMorty. The three of us are pairing up to bring back to life the Chasm podcasts. We're actually going to call it the Canadian Sports Medicine Report. And we're going to be interviewing some of our esteemed colleagues with timely topics, reviewing recent research, event information, speaking to professional athletes and coaches, so that we can make sure that everybody stays informed and involved. We promise that it's going to be Subway worthy, we're going to try to aim to keep it less than 30 minutes, none of these 2-hour podcasts that you can fall asleep to. So look us up. We're going to be on SoundCloud, Spotify, Apple podcasts, and anywhere you want to get your podcasts. So I'm going to introduce our first presenter tonight, Robin McKeever. Robin McKeever is a former Olympic athlete, and he participated in cross-country skiing at the 1998 Winter Olympics in Nagano. In 2001, Robin went on to become the sighted guide for his brother, Brian McKeever, who's currently Canada's most decorated Winter Paralympian. Together, they raced and won multiple medals during the 2002 and 2006 Paralympic Winter Games. In 2010, Robin became the ParaNordic ski coach for Cross Country Canada, and under his leadership, the ParaNordic team brought home 16 medals. Holy crap, 16 medals, that's awesome. From the 2018 Pyeongchang Winter Paralympics. During the same year, he was awarded the Tim Frick Paralympic Coach Excellence Award. So, Robin, the floor is yours to present to us challenges of preparing for Winter Paralympics 2022.
Well, thank you very much, Rich. And I think the number one and biggest challenge becomes Wi-Fi and connectivity through virtual media and virtual stuff. But I'd like to, for sure, thank the MDs and healthcare workers, because this has been a very challenging year for everybody. And first and foremost, my heart's out to everybody in the healthcare who we work with to keep athletes, staff, coaches, sport healthy, but also all humans in general. I attended the Chasm conference actually in 2019, and it was one of the best, coach education pieces of my coaching career. And just the stuff that we could learn from in that scenario was just awesome. So when I was asked to present about what are the challenges of preparing for Beijing 2022 through COVID, it's been one of challenges for everybody. But for me, this really started 1 year ago, because I was preparing for Beijing in March of 2019, and March of 2020, and was in Japan actually a year ago today, looking for the proper altitude and elevation for a staging camp before Beijing. And my wife told me, you can't go to Asia, you can't go to Japan. There's this new virus there, and we have to be really careful. And my response at that time was, as long as international air travel is still open and available, it's really difficult to stop this. And I'm going to do everything possible, which at that time was before Canada had masking, was traveling with masking, hand sanitizing, wiping down everything in the aircraft that I was going to touch, and just crazy change. And from Japan, I came home for about 3 days and was in Sweden actually for World Cup finals for ParaNordic, when at 2 a.m., Trump announced on March the 11th, it was 2 a.m. in Sweden, that he was closing his airspace. And at that time, I woke up the WAC staff, got on the horn to Air Canada, and got 15 people out of Sweden the very next day, which entitled going to a wax room at 3 a.m. and packing a whole bunch of ski bags, waxing about 100 pair of skis, and getting all the ski bags out and to an airport by noon the next day for actually a noon flight. We didn't know what time we were leaving when we first went to the wax room, but that's where we started from. And that was our big preparation for, what I call the sideways hustle that is sport in today's scope. So I'm just going to share with you screen on what I presented to Own the Podium as our original plan, and then the two other plans that I've had to shift in this past year. I suppose I have to share this first. So this is from, and the top section is what I had presented to Own the Podium, and it includes a whole whack of camps that are all outside of Canada, 3 specifically, 2 in US, 1 in the spring and 1 in the fall. And our main camp of the year is always in August at New Zealand, at a place called the Snow Farm, where we do a lot of specific on snow skiing for 3 weeks in August. This has been something that I have done 13 years in a row. And I guess it's unlucky 13 because in 2021, that obviously had to change since New Zealand was shut down. Right after we presented to OTP, we knew that we were not going to be able to do our normal training plan. And I shifted to stay at home, stay safe, and stay healthy plan that included doing a bunch of virtual racing and ideas. And then we tried to do as much training as possible if we could get people to Canmore, or at least the majority of the team lives in Canmore. So we're quite fortunate in that way that we can access a lot of places of altitude around Canmore. And then the bottom plan is the plan that had to be shifted in about November, when every single World Cup that we were supposed to go to for ParaNordic got canceled. And I shifted right away to going to a physiological ideology. And that's where we started from today. So let's go back. There we go. Sorry about that. At any rate, the 3 main focuses that I had for the whole team was physiology and what we were going to do to best prepare for Beijing, because Beijing is at a very high altitude compared to general racing. We're at 1,660 meters at the stadium in Beijing that we'll be competing at. So that was the basis of the plan going forward. the mental health of the athletes, because in every preparation here on moving was some pretty difficult times, and just watching athletes, even who had daily training regimens in Canmore, just seeing how they were concerned about not racing and trying to stay safe and healthy and away from, any issues. And last but not least was actually a technical plan of how we are going to best operate as a team overall and stay mentally fresh and sharp going into a Paralympics in a year's time, that we weren't in control of the actual environment as of yet. So the one piece that I can say that I'm quite happy about and very fortunate of is that I have actually been on the ground with our head technician in Beijing before there was even a course layout. So just by fluke, we got to go in and we got to walk and run on some bulldozed dirt that will end up being the Beijing Paralympic site and the biathlon venue for the Olympics. So going there and actually feeling it, and just by fluke, it actually snowed one of the days we were there. So we actually got to see what the environment would look like. So that is extremely fortunate in planning our whole Beijing block that we came to, that I'm currently in right now. So we've just started a camp in Canmore, which was originally slated for Apex, BC. It's at a high altitude, Apex itself, and the cross-country ski area. But going through the provincial health regulations and everything like this, we were asked not to come. And so these are types of things that you have to, I guess, be prepared for your sideways hustle and shift very quickly. So this was 2 weeks before this Beijing block camp was planned, that we were finally told that we could no longer come to BC and they would not accept our proposal moving through. Shifted very quickly to majority of the athletes are already based in Alberta or in Canmore. So we do have access to some high altitude here. So that got to some very quick phone calls to the government of Alberta and Alberta Parks, to get grooming and everything in place at the one venue called Mount Shark, which is about 45 minutes south of Canmore, located at 1,700 meters. And so the whole plan comes around the physiology of the altitude that we want athletes prepared to race at. And there's nothing like racing at that altitude, except for going and experiencing it for yourself, because what you think is just easy within 10 minutes of starting a race turns into lactic acid buildup that you cannot recover from, and you don't know what's happening. And it's very fun to compete at that level and have that happen to you, not in a good way fun, but learning what that is. Your body just doesn't react the way you're used to it reacting. And shifting that altitude without doing it on a regular basis becomes quite difficult. So the whole season, especially training, was around getting used to different altitude shifts. And really the physiology that I follow is always around altitude shifting and utilizing altitude then to springboard into intensities, and trying to get as much as we can physiologically. So where we're at, we have coming up here, we have 4 time trials that we are trying to actually get World Cup points associated with, or ParaNordic points associated with. Every race that we can do that's considered somewhat official, we can associate points with. But in Canada, we have a total of about 15 para athletes to get points from. So qualifying for the games of Paralympics this year at the end of the season, we must qualify our status numbers or our quota spots. So if I can get ideally 12 spots, we currently only have 8. I would need 4 more athletes to make an average of 180 points. So this is competing and have an average below that level. And we only have, with only 8 athletes, we have to average points out. And these new athletes coming in have to compete at a level high enough then to make their 180. So we're dealing with a lot of math, which is not really competition, but they still have to come in here and compete against our athletes because we don't travel very easily outside of the country. As of 4 weeks ago, we were told that there will be a World Cup finals in Finland, which has come up just in the last, like 4 weeks. Is not a lot of time in our current health environment to plan a big team trip outside of the country. At the same time that we knew this was coming down, we also knew that there was going to be mandatory quarantines and hotel stays and a whole bunch of, implementations to try and keep our society healthier. This is a massive balance with high performance sport when your whole criteria and everything and whole mental aspect of where you're going is focused on qualifying for games and competing as best you can in Beijing. So that Finland idea of going to the World Cup becomes where we look at the mental health of athletes and specifically choose athletes that I believe, one, need extra racing because they're new to the sport. And in para, especially in sit skiing, we can transfer athletes very quickly. There's limited technical, it's just double pulling. So it's upper body strength and endurance. Obviously the endurance component comes through, I say about, if I have to really shift athletes, it's about 6 to 8 years of endurance training. But the mental capacity that we require around that type of racing and just experience becomes so critical going to Beijing in a year's time that there's a couple athletes I believe need extra World Cup starts. They've only had a handful, and it's possible that they could be performers for our program next year and in the future. And then, of course, athletes who I believe have taken a big step forward that really need to prove it to themselves for the psychological advantages moving forward. So we have 4 athletes who are interested in going, and this was totally up to them. We cannot, in this environment, have any real constrictions or restrictions on athletes coming or going, in that it really has to be up to their comfort level on what they want to do. So even coming into the province of Alberta from another province is really totally been up to the athletes and whether they wanted to join us in any opportunities at camps, environments that we put forward. At any rate, the bigger issue for the technical piece for our staff going to a World Cup at the end of the season here is just around actually functioning in the high performance environment and waxing skis and working as a team in that space. So we have 2 wax technicians, 1 service staff member, and our biathlon coach and myself, cross-country coach, working together to operate the last World Cup of the year. And we're all going there fully knowledgeable that we're coming home to a hotel environment and covering those costs within our program, and then staying at home for the 11 days post-hotel. So this is really interesting and challenging times. And it's been a sideways hustle on every single step of the way. And every week something has changed or something has shifted, and we have had to take on the dance and move with it. So the bigger thing is, I think, for me, sort of in closing of wherever the focus is with the athletes, is just within any challenge, I try to focus on the global health and wellness of all the athletes on an individual basis. And if I can keep that in perspective, I believe that I can do what is best for the team as a whole, and then keep the athletes as healthy as possible, and they're in control of their destinies. So I'll open up to some questions if we have any that have come through.
Awesome. Thank you. And yeah, I totally agree. We've got, if you have questions, just go into the Q&A section of the Zoom and type in anything you want to know in there. Kathy Campbell says, thanks for the excellent talk. Lots of challenges. I guess, what do you see as the reality of how things are going to roll out over the next, 12 to 24 months with everything that's going on. And obviously challenging to plan, and you got to fly by the seat of your pants. And how's that going to play into, A, preparation, B, injuries, because you're throwing people into a sport or into, activities and sporting competitions that they may not be fully prepared for, both mentally and physically. Like, how do you see that playing out?
Well, those are very good questions. I think from how the sport plays out, I think we're lucky that we've had the athletes, and what I've done this year is gone to the athletes. So I did one camp where I went out east in about September. I ran a camp in the Niagara area for sit skiers, and we were in like sort of the farmlands and doing a lot of roller skiing, a lot of sit skiing out there, and did a week-long camp where we really focused in on technical and some hard intensities there, so they're prepared. And if we're training on asphalt with the poling and stuff, especially with sit skiers, we tend to be able to really mitigate injuries on snow. Snow tends to be softer and easier to work with at that point. The other thing is where we're going. I don't even know. Like, I have to be prepared that Japan, where my staging camp location is, will likely be closed. I've already not planned in the future, this next summer coming up, that I will not be going to New Zealand. There's no way that country is opening up in August. So I've already shifted the entire focus of where we are going and what we're doing, and utilizing some altitudes around the Canmore area, and shifted camps. So a really cool place to do training that we found that is usable for sit skiing and standing skiers, and everything is actually at the Glacier View Lodge, was at the Athabasca ice fields, and it is located at 2,000 meters. So we can get out of the hotel and roller ski on the highway that's right outside the Athabasca ice field. And we're at 2,000 meters. And if we get up early enough, there's actually not that much traffic, as we found out in the fall. Speed Skating Canada is also using that hotel in the summer to do some of their altitude training that they are using as well. So just these different ideas of how we can shift from what we were used to doing, and the same patterns for the last 13 years, for example, with subtle shifts, all of a sudden become, okay, how can we actually do this and potentially make it even better? And so, yeah, moving forward, that becomes a huge factor. I'm extremely lucky to have a really strong IST team that we've built around us, which includes one of your panelists tonight, Dr. Andy Reid, who gets to speak with you, and physios, chiros, massage therapists that are all part of a really exciting team that I love to be part of. And that makes it, them being part of us helps the athletes, and I believe in a real good staff environment that everybody happy to be part of, and then the athletes are well looked after and they feel like they are really important.
You're just on mute there, Rich.
I was trying that space bar trick. We just press the space bar to unmute and it didn't work. Sorry. Yeah, like the team is much more than the tip of the iceberg that you see with the athletes. There's a very robust coaching staff and rehabilitation staff that go along with the team. So yeah, and to mobilize all that, it's definitely a challenge. So we got a bunch of questions. So I'm going to fly over here. Maureen says, if your athletes leave the country for competition and training, are they quarantine bound for 14 days coming back home? And how do you balance the drop in training versus the important?
Okay, so that was broken up a little bit. I might be my Wi-Fi, but so you're correct. That's a very good question. The reason we haven't gone anywhere up until now is because of we are mandatory to quarantine for 14 days upon return. And we have not left the country up until now because of that specifically. We are used to traveling to Europe for about 2 week to 3 week blocks, coming home for 2 to 3 week blocks, and then going back. And that would be a typical World Cup trip year for a ParaNordic team. This year, though, everything did get canceled. And then when 2 events did come up, like literally a month ago, 2 events came up for World Cup in Slovenia, which I decided after looking at all the COVID risks that are there and the COVID cases that was too high of a risk for our program to go in there and then bounce to Finland. I didn't want to take that on, especially when the physiology piece that I already shifted to in November becomes a far more important piece of my puzzle going into Beijing, or the puzzle for the para athletes. And then, yes, Finland, though, we will have to come back, and that's our year end at any rate. So we'll arrive home on March 27th, and April is typically a month off. So then we have the 2 week block or period right there where athletes can utilize, let's call it recovery from a stressful year. And I know that some of the coaches and staff will be bouncing around. I'm actually looking somewhat forward to 2 weeks where I can just sit down and focus on presentations for Own the Podium and what we're actually really going to do. So the plan is already set for the next year, but then presenting and how we're going to go forward, I need a couple of weeks to focus, and that'll be actually timing to go into our OTP presentation.
Awesome. Okay, Chris Beavington says, where are the ideal altitude training locations in Canada?
So there's about 2 provinces in the country that have altitude available at that level. Well, if we go north, I guess Yukon as well, but BC and Alberta close by, where we can get to the 18, for me in endurance, 1800 meters becomes our magic level. And if we can get above that and build up to it, so our fall camp becomes over 2000 meters, this becomes what I've seen with our team over the last 10 years is an ideal preparation for the altitudes and altitude shifts. The danger that I have, or the difficult part that I have, is looking for wheelchair accessibility and hotels at that high level over 2000 meters that are wheelchair accessible and everything else. I know of about one, and that is at the Glacier View, which is an elevator and usable, but it is also in the Banff National Park, right at the Athabasca Glacier, and not always the most affordable option. So a lot of things that we need to balance out in all of that, for sure.
Awesome. Okay, Kathy Campbell says, mental health is one of the most difficult areas generally through COVID times. Can you speak to how you and your athletes monitor this and deal with the issues regarding mental health?
Well, very good question. Not easy answers. My way of dealing with it is having some close friends who happen to be psychologists. And so I have lots of good communication with them and strong communication with them. The other piece is I'm really lucky that we have a small program overall. So there are 7 World Cup athletes I'm directly responsible for, and only 7. So I can reach out to them, or they can reach out to me, and I have weekly or daily communications with many of them. But if some I don't hear from, who are away from Canmore Central Daily Training Environment, I will reach out to them. We have lots of back and forth and keep that communication open. Plus, they are what we were doing early on and tried to maintain through is about a weekly team. We did some core sessions together, but a weekly team Zoom meeting where we got the whole group together. And when the group gets together like that, it's usually joking and fun and just feel the connection for the team that way. And that was how we dealt with that for the most part. But lucky to have a good team psychologist that is open to having the athletes contact him directly, and he will reach out to them. And that was also part of our team building through the summer.
Awesome. Okay, anonymous attendee says, what do you do for your athletes that don't go to the World Cup? Like they didn't qualify, or they decided not to keep them motivated in training this season, or continue to prepare them for Beijing? Or do all of your athletes qualify and go to the World Cup?
Well, because of the World Cup, there is only 6 races at the end, and it's World Cup finals. And with the COVID currently. The World Cup team of 7, like I told you, had the option to go. Only 3 chose that option. They believe that this Beijing block that we're putting into place now becomes precedence over the World Cup, and they are already, the World Cup team themselves are pretty much all already have a qualifying slot. What we really need to do, though, is next year, the first World Cup of the season, assuming it goes to plan, is actually in Canmore in December. And from there, we can really test the athletes, and hopefully in a safer environment where people are a little bit more, can breathe easier, let's call it, and feel ready to go. And then from there, we can select our teams to go to Beijing. We also have a World Championships in January of 2022 in Lillehammer, which will be our last sort of competition event before Beijing. And I'm assuming that it's going to happen in January in Norway. It was canceled from this year or moved to January. So that's, again, a big assumption. From there, we will have to apply for bipartite status for athletes that we need to go. But that becomes the main reason to have 12 quota spots qualified this year is to make sure that we get our staff quotas for accreditation for the games, because like I said earlier, we need to have the set number of staff that we're used to working with to best provide for the athletes that I'm comfortable with taking in there.
Awesome. Okay, so Connie Lebrun says, awesome talk. Thanks for sharing your challenges coaching the ParaNordic skiers. And Gwen DeVries says, solid talk. Thanks, Robin. Keep that side shuffle. Very good approach. Any special planning for time zone shifts, rehearsal a few months in advance of the games?
Well, probably not a few months in advance, but going in, if we cannot stage in Japan like planned, which is a 2-hour time difference from Beijing, that's sort of the plan to get our time shift in. Now, obviously, with not being able to go into Beijing at all, because this week I would be supposed to have been in Beijing racing World Cup, but of course, everything is closed in China, pretty much. And so we will start to get onto the time zone of Beijing in Canada with a few hours shift, but our plan is to go as soon as possible that the Paralympic Village is open to move to Beijing. So that will be the new plan. Typically, I go to a staging camp and go into the Paralympic site with only about 4 days ahead of opening ceremonies. And this is the first time I've had to shift the whole thinking, because none of the athletes have been to Beijing. Before Pyeongchang, all the athletes had been on site 3 times for 3 different sessions before going to the games. And I had actually been to Pyeongchang 5 times before the game. So I was very comfortable with that environment and knew just where I was going for everything. This year, I just consider myself lucky. I've been to Beijing once and been to the site. So I have a better idea than most, to be quite honest, of how it actually looks. And that to me is crazy.
And how does it look?
Windy. It will be very windy. It will be colder than we expect. Pyeongchang was actually quite windy for the Olympics and cold. This will even be colder and windier for Olympics. For Paralympics, there is the chance of freeze-thaw conditions above 0, but it is typically very windy and dusty, dirty. So I'm preparing for colder snow, but also a lot of dirt and dust within the snow. Yeah. It will be interesting. And just China is just a different, crazier environment than any other Paralympics or games that I've been to before.
Yeah, you're going to give your wax technicians a real workout.
For sure. And so I think the only thing that we have going for us is having been to Beijing and been on site, knowing that there's typically very little snow. We know that'll be all artificial snow for the most part. Any snow that comes in there is quite dry. And it's very similar actually to Canmore, which is, not coastal at all. It's inland, it's windy, can be dry here as well. And so we will utilize that as best to our advantage for wax testing and whatnot, as we have done this whole winter just being here. So we see that as a a real positive advantage for our sake as well.
Yeah, big plus. So Chad Workman says, I understand that traveling to altitude during COVID is a challenge. Do you have any options to train in an artificially induced hypoxic environment at lower altitude? Might be useful as an option, particularly during your quarantine times.
Yeah, it is quite possible. In the past, CSI Calgary, when I was an athlete, we had options to go into a chamber there and do training, but it's nothing specific, of course. It's on a stationary bike, and there's times you can put a treadmill in, so it's not specific to cross-country skiing. So you can get some endurance in that hypoxic area. Of course, we don't get the same physical effect without going to the altitude. So far this past summer, going to altitudes from Canmore, we can easily just, the standing athletes can easily run up a mountain back here and train across the tops of the peaks here, close to 2,000 meters. So we're doing a shift in that type of training. The sit skiers, I can easily drive with and go up to Highwood Pass in the summer, which is at just over 2,000 meters, 2,200 meters as well. And the sit skiers can bike up. And at the top, we put them on arm ergometers, and we do lots of endurance training like that and set them up that way. This doesn't change a whole lot. Where we tried to go down to the US in June, and then again in September, October, is to go to warmer climates to get our altitude in, because altitude in Canmore, around Canmore, Calgary area, in June can typically be, -0 degrees snowing or -5 and snowing at that altitude. And it's not easy to put in the volume at those temperatures.
Yeah, for sure. Okay, I'm going to wrap it up there. If there's any other questions that you might have for Robin, please put them in the question and answer chat. And Robin, go in there and you can just hit type answer, and you can answer any of the questions right now. I think there aren't any pending questions. Oh, there's a couple in the chat from Andy and Patrick, but I'll let you address those. So we're going to move on to our next talk. And Dr. Andy Reid, look at that. You got like a radio pose going there. Look at the old lean in. Dr. Reid is going to speak to us about the cardiorespiratory considerations in cold weather training. So Andy's a sport and exercise medicine physician living in Canmore with his wife, Sarah, 2 kids and 2 dogs. He works at the Banff Sports Medicine Group, and he trained at the University of Newcastle upon Tyne in the UK, graduating in 1994. He completed a residency in family medicine by 1998, and then decided to jump across the pond in 1999 to come live in Canada, and picked the most beautiful spot in Canada, Regina, Saskatchewan, to settle his first roots in January of 1999, where he was immediately acquainted with extreme cold weather and winter sports. So he moved to Canmore in 2002, where he took on a role with the Biathlon Canada and then Cross Country Canada. And he decided to close his family practice in 2013 to focus on full-time sports medicine. He's currently the team physician for national biathlon, cross-country skiing, and ParaNordic teams based in Canmore. He's a keen runner, with 100 miles being his preferred distance, and his wife states it takes a special kind of idiot to enjoy 100-mile racing. And I got to agree, your wife's a smart woman. He's completed 8 100-mile races with top 5 finishes in several of North America's most competitive fields. Wow, we are blessed to have you tonight, my friend. Anyways, Andy, the floor is yours. We look forward to your talk.
Okay, hey, thanks, Rich, and thanks everybody for tuning in. Can you hear me okay there, Rich? Yeah, awesome. Okay, I'm going to share my screen here. Let's see if I can get this to work. There we go. Can you see that okay? Yeah. All right, so this is a big topic, so hopefully I can get through this in 25 minutes. So thanks for the introduction there, Rich. As you mentioned, I work for Banff Sport Medicine. I look after a couple of Nordic teams here in Canmore. I'm a runner and a skier. I have no financial disclosures other than I do receive a stipend from the teams that I look after, and the occasional pair of fast cross-country skis from guys like Robin, if I'm lucky. So the goals of this talk in the next 20 minutes, hopefully I'll describe some of the effects of cold weather on athletic performance, describe some of the changes that occur in the respiratory tract and the cardiovascular changes that can occur with cold weather exercise, and hopefully give you maybe some practical tips that you can use when talking to your patients about extreme cold exercise. So when we think about athletic performance, obviously there are lots of factors that play into that. But when we think about the weather and the weather's effect on athletic performance, there's across a variety of sports, there's an inverse U-shaped graph such as this. And this essentially what this graph shows is that performance declines at very high temperatures and performance declines at very low temperatures as well. It seems like there's a sweet spot right in the middle. This study that I quoted here first showed this pretty nicely in '97, and it was a cycling study. Well-trained cyclists basically did a time trial at about 70% of their VO2 max, I think it was, and they performed that time trial at 4 different temperatures. The lowest temperature was 3 degrees, the highest was 30 degrees, and basically they just went until they could go no more. And essentially their performance was worst when it got very hot and also when it got very, very cold. So they demonstrated quite nicely the inverse U-shaped graph. If we think about marathon performance, so another endurance event, this was a great study that I came across, published by the American Academy of Sports Medicine Physicians, and this study they analyzed 7 different North American marathons. They looked at finishing times, and they went back 36 years. So they analyzed a huge amount of data, and essentially what they showed was that as the temperatures went up, the finishing times got progressively slower. So the fastest times actually occurred at the lowest temperatures, but the lowest temperature that they looked at here was only 10 degrees Celsius, which is actually not super cold and is probably about the ideal temperature for marathon running. So I was thinking about this, and I was basically thinking they didn't go cold enough. So I thought about what's a cold marathon, and the 2018 Boston Marathon was one that sprung to mind. Some of you may have even run in that race, but it was just an absolutely awful day. The wind chill put it around about -10, I believe, and the finishing times were significantly slower than one would normally expect in that race. The women's winner, Des Linden, she finished in 2 hours 39, which is way slower than you would typically expect. The female winner of that race, the course record, I believe, it's under 2:20. So we know that as the weather gets colder, marathon performance also declines. Those last 2 slides, we're looking at time trials and marathon running. So long steady state efforts, pretty close to lactate threshold. So what about intervals? Well, this was a trial that was done looking specifically at intervals at 4 different temperatures. These were well-trained cyclists. They were all pretty fit. They had an average VO2 max of 70. So these are all pretty high level cyclists, and they performed a pretty classic VO2 max workout. So after a warm-up, they did 5 by 4 minutes. 4 minutes hard with 5 minutes rest in between each interval. So pretty classic VO2 max workout. Again, they showed exactly the same thing as we saw in the marathon runners, that the performance decreased as the temperature rose. And interestingly, they went down to 5 degrees Celsius and showed that there was really no difference between 5 degrees and 20 degrees. So again, my thought on this is they probably didn't go cold enough to see a significant performance decrease. So it certainly seems that there's this inverse U-shaped curve is true. So this is really cold weather. This when Rich asked me to do this talk, I was lucky enough that we hit a really cold snap here in Canmore. And this is my wife, who in the introduction called me an idiot, I believe. And she's out here running at -36, which is probably not the most sensible thing to do. And I certainly don't advocate this, but this is really cold weather. So, when we think about really cold weather performance, what does that do to us? Well, there's actually really not a whole lot of published data on the really cold athletic performance. I had a look around, and I was able to find a few studies. This was a study looking at double poling power in elite cross-country skiers. They basically put these top skiers on a ski erg, and they basically did some max intervals. They looked at 30-second intervals and 2-minute intervals, and they were tested at 2 temperatures. They were tested at -14, which is pretty cold, although not extreme, and +6. And they showed that there was between a 5 and 7% reduction in their peak power output at the colder temperature. There's also studies showing that, when it gets really cold, running economy suffers, and probably due to changes in our muscle and tendon elasticity, which essentially makes us run with shorter strides. We get less bounce in our stride and decreased speed. And then there are also studies that have shown that at really cold temperatures, for a given workload, we actually see increases in blood and muscle lactate levels at the really cold levels for a given workload. So this tends to suggest that we switch a little bit more to anaerobic metabolism. We probably utilize more of our type 2 fast twitch fibers when things get really cold, and one would expect that would typically shorten the time to exhaustion. So if we come on to some of the health considerations, the cardiovascular and respiratory considerations in cold weather exercise, I'm going to focus mainly on exercise-induced bronchoconstriction, EIB, what used to be known as exercise-induced asthma, although I don't like that term particularly. There are other considerations that I'm not really going to touch upon. We know that winter athletes do tend to have a higher incidence of URTIs, and then the drippy nose, which you've probably all experienced when out exercising in the cold. I'm not going to focus on those two things. So if we look at EIB, here's just a quick plug for beautiful Canmore. This is our Nordic Center. If you're ever visiting town in the winter months, you really have to go up here and ski. It's a world-class venue. You'll love it. So if we think about asthma and EIB, so exercise-induced bronchoconstriction, essentially that is airway narrowing that occurs only with exercise. And subjects with EIB, they may or may not have asthma. We know that about 10% of the normal population will have EIB if tested, but we know that 90% of asthmatics will also have EIB. Asthma will typically have other triggers other than exercise, but as I say, 90% of asthmatics do have exercise-induced symptoms. And the symptoms are usually transient. They occur during or after exertion, typically a fairly rapid onset after stopping exercise within 5 to 15 minutes, and they resolve spontaneously within the hour. Typical asthma symptoms are usually present: coughing, wheezing, chest tightness, all the usual stuff. We know that these symptoms are certainly commoner in endurance sports. They're commoner in cold weather sports, especially, and especially in sports that involve high respiratory rates. So sports where we're breathing real hard, that seems to be a trigger for exercise-induced bronchoconstriction. And we know that, as many as 50% of Olympic cross-country skiers will actually report these kind of symptoms with intense exertion. We believe that the main cause for EIB is airway cooling and airway drying. When we're breathing large volumes of cold air in and out of our lungs, then that drying and cooling causes airway engorgement. It causes increased sensitivity in our smooth muscles lining our respiratory tract, and that leads to bronchoconstriction. And as I said, increased ventilatory rates seem to be a significant trigger, basically because we're moving more air in and out, so we're exposing our airways to increased volumes of cold and drying air. And we do lose that, once we start working hard, we also lose the humidifying effects of nasal breathing at those higher ventilatory rates. When we're sitting here at rest, we're mostly nasal breathers, and we take in about 5 liters per minute. And our nasal passages, their main job is to humidify and warm air. And we know that, if you go out and cross-country ski, you're going to be moving 20 to 30 times that amount of air in and out of your lungs, and there's no way you can breathe through your nose when you exercise that hard. Interestingly, we know that the respiratory symptoms that occur in cross-country skiers tend to occur later in life, and it's been suggested that this suggests that chronic long-term damage from cold air exposure may well be to blame. And I'll go into some of the changes we see at bronchoscopy on my next slide, but essentially we see changes at bronchoscopy and on bronchoalveolar lavage, which suggests that there is a degree of chronic damage. Normal asthmatics typically will develop symptoms in childhood, whereas we know that cross-country skiers tend to develop their respiratory symptoms later on in life, typically not until adulthood, as I just said there. So, what evidence do we have for airway damage? Well, we know that if you bronchoscope cross-country skiers, and also interestingly, there's a great paper looking at bronchoscopy in Alaskan sled dogs who have just completed the Iditarod race. This is a huge race in Alaska. I think it takes 8-9 days to complete this race, and these sled dogs race across the Alaskan tundra in really cold conditions. And basically, when you bronchoscope the skiers and the dogs, what we tend to find is more friable mucosa in the airways. We see increased vascularity and bleeding, increased edema. There are inflammatory changes, such as neutrophils, lymphoid aggregates, basement membrane thickening, which suggests airway remodeling. And interestingly, if you bronchoscope an asthmatic, we tend to see a slightly different infiltrate. We see more eosinophils, we see more mast cell infiltrates, and this suggests that there are two different mechanisms at play here. So as I say, all of the above suggests that airway damage plays a part. Unfortunately, we don't really know if this is permanent, and as far as I'm aware, there hasn't been any long-term follow-up, so we don't know whether skiers, when they retire, whether these changes are reversible. This is Devon Kershaw, who is one of Canada's top cross-country skiers over the last decade, and one thing that I always mention to my patients is that asthma or EIB does not have to hamper your performance. So Devon suffered with exercise-induced bronchoconstriction. He needed inhalers all the time and had some great results. So you still can perform at a very high level with this condition. So I've talked a lot there about some of the elite athletes. So what about recreational skiers? What about the average guy out there? So this was a nice study performed in Finland. We actually have the Scandinavians to thank for a lot of the data that we have on these conditions, particularly Scandinavian cross-country skiers. So basically, the author in this study looked at the prevalence of symptoms, and just bear in mind these weren't tested people; these were people who just reported symptoms. They took 7,000 plus recreational Finnish skiers. Now, what a recreational skier is in Finland, I'm not quite sure. They didn't define recreational. I would imagine the average recreational Finnish skier is probably pretty good, but nevertheless, these were not elite skiers. And they found they found a really high prevalence of respiratory symptoms in both the recreational skiers, but also in non-skiers. And Finland is a pretty chilly place. In January and February, their average temperature is around about -13. And while I was digging through some of these clinical trials, I actually found that in Finland, they define hot weather as greater than 13 Celsius, which I don't think we would consider as particularly warm. But nevertheless, they showed that there was a high prevalence in both the skiers and the non-skiers. Now, when compared to the elite skiers, elite Norwegian skiers, the prevalence in the recreational skier and the average person was still significantly lower. And as I said earlier, asthma-like symptoms have been reported in as many as 50% of elite skiers. So it seems that maybe skiing fast, maybe being elite is the problem. Skiing fast in cold air may actually be the problem, and skiing slower in cold air may not be so much of a problem. So diagnosis of EIB, well, symptoms, a lot of us will have symptoms of EIB. A lot of us will cough. A lot of us will wheeze a little bit when we exercise in cold air. But interestingly, we don't all have positive tests or objective tests of EIB or asthma when we're tested. So, I would always recommend, if you suspect that your patient has this condition, that I'd always recommend an objective test. And especially if you're looking after high-level athletes or elite athletes who may be subject to drug testing, then certainly you should be getting an objective test to confirm the diagnosis. It's always worth being aware of the WADA guidelines as well. These things change. They seem to change on an annual basis. So I always have to remind myself to check the WADA guidelines on the first of each year, because they do change. My suggested algorithm for diagnosis would be, if you have a patient with suggestive symptoms, always start with spirometry. That's the way you would confirm if this person has asthma or not. And obviously, if asthma is confirmed with spirometry, then you should treat that in the usual way. If their spirometry is normal and the patient has symptoms, and they're an athlete, then I would recommend performing some kind of a provocation test. And the best provocation tests seem to be either an exercise challenge or an EVH, a eucapnic voluntary hypopnea test, which isn't widely available. We're lucky here in Canmore that we can refer patients into Calgary to get that test done through the Sports Institute, but it may not be widely available. An exercise challenge is probably the next best test. We have a respirology office here in Canmore, and what we typically do if we're trying to provoke symptoms is we have the athlete run up and down on the road outside the clinic for half an hour or so in cold weather, and then we perform their spirometry. Methacholine challenges, which are more widely available, can be used and can be useful, but they seem to be a little less consistent in EIB. And then if you go through all of that and you still have negative results, then obviously it's still important to consider alternative diagnoses for their respiratory symptoms, such as cardiac causes, vocal cord dysfunction, anxiety, and other pulmonary diseases. Treatment, I'm not going to spend a whole lot of time here on treatment, but a few interesting points when you're treating exercise-induced bronchoconstriction. Inhaled beta agonists are generally very effective, but they shouldn't be overused due to the development of tolerance, which can actually occur as quickly as within 72 hours. So, for the skiers that I advise who are using using Ventolin before they train, I would usually just recommend that they use their inhalers on the days where they're going to be working especially hard. If they have a hard workout, if they're doing some intervals, then, or a time trial, then those would be the days to use it. And on their easy days, which is the majority of their training, those slower easy days, then we can often get away without them using any inhaler. Steroids, inhaled steroids in the absence of asthma don't seem to be as effective, but can still be effective, but they seem less effective in the pure EIB patient. And then the leukotriene receptor antagonists, so that's your singular, in my experience, can be really effective in this condition. And a lot of athletes kind of like just taking a pill once a day, as opposed to worrying about an inhaler. And they are very effective. Mast cell stabilizers like cremoglycate, also effective, and then anticholinergics like your Atrovent. The effects seem to be variable, but I've definitely had skiers who respond pretty well to that, typically when used in combination with other treatments. So prevention, prevention is probably better than cure. So my advice to people wondering about training in real cold weather is, maybe the best thing to do if it's below -20 is actually not to go out there and train. So certainly the teams that I look after here, if it's below -20, we typically move them indoors for training, or we adjust their training. We take the intervals out of their session. But I think it's certainly sensible to move training indoors if it's -20 or below. A good low intensity warm up does seem to be quite helpful at preventing subsequent bronchospasm. Most of the data suggests that a 30-minute low intensity warm up can reduce bronchospasm afterwards. It seems like there's a refractory period of an hour or more. So again, that's, if you're looking at racing in cold weather, that's a good thing for them to do, is a low intensity warm up. Obviously avoiding interval training in really cold weather. And then down the bottom here, this may be something that this may be new to some people, but these HMEs, or heat and moisture exchange devices, are actually pretty prevalent in the cross-country ski world. These are, I don't know whether anybody's seen this kind of thing before. A couple of these pictures are from Canmore. The picture on the top right there is Laura Dahlmeier, who's an Olympic biathlon champion. And that picture was taken in Canmore during one of the World Cups that was here, where it was pretty close to -20. And basically, these devices warm and humidify the air that's breathed in. They contain a filter. The exhaled air basically warms and moistens that filter, and then when they breathe cold air in, it's partly warmed and partly humidified before it gets into the lungs. And these things are, as I say, they're in widespread use on the World Cups, and most skiers seem to use them during their warm up, but it's rare to see them used in racing. I guess, racing with that thing in your mouth is maybe not the best, is maybe not ideal. And there's actually a handful of studies that have shown these to be a really effective strategy. So a recent review last April looked at these very devices, and they showed that skiing around with one of these things in your mouth was probably at least as effective as taking a bronchodilator. And there were some pretty dramatic results. I listed a few studies there, and they showed quite marked attenuation in the FEV1 drop that you would expect with cold weather exercise. 36% drop, reduced down to 11% FEV1 drop with one of these devices is pretty dramatic. This is my own version of the heat and moisture exchange device, the Buff. I don't know whether anybody's looked at that, but this seems to be a pretty reasonable option if you don't have one of those HME devices. Okay, I'll move on to some cardiovascular considerations here. So this guy on the right here, this is a Dutch madman called Wim Hof, who you may have Some of you may have read his book or heard about him, and he seems to spend a lot of his time sitting in icy cold rivers and streams and lakes, and he believes that repeated cold water exposure is the secret to the doorway to his soul, and he believes that it will unlock superhuman powers. So is Wim Hof right? Well, we know that cold weather increases cardiovascular events. You know, we're all aware that there are more hospital admissions with cardiac events, with angina, with heart attacks in cold weather. Again, we have the Scandinavians to thank for a lot of the data. In Finland, it's estimated that an additional 2,000 to 3,000 deaths are directly attributable to cold weather each year. And it seems, again, interesting that it seems that the early season cold snaps are the worst. So we see more people hospitalized, we see more people in the emergency room early in the season with cold weather. So it may be that we can adapt to some extent. So maybe Wim Hof here is onto something with his sitting in the cold water. The major effects of extreme cold and cardiovascular risk, well, as I've said, we see more myocardial infarctions, we see more angina, we see more hospitalizations. There is more mortality, more people die from these conditions in really cold weather, and we see increased risk, increased incidence of stroke, especially in women. And of course, all of these things seem to be related to an increase in blood clotting, an increase in thrombosis. We essentially become hypercoagulable in cold weather. And it's been shown time and time again that we have increased fibrinogen, we have increased platelet counts in extreme cold weather. When we exercise in the cold, because of the peripheral vasoconstriction that occurs and the increase in the peripheral resistance and the shunting of blood away from the periphery into the core, we do tend to see a higher cardiac load. This effect is pronounced in vasculopaths, so who have stiffer arteries. And if you perform exercise tests on patients with cardiovascular disease in the cold, we certainly see more ECG changes. And then we also see more ICDs discharging in cold weather. So it would appear that there are more arrhythmias occurring in very cold weather. Blood pressure also goes up, and it seems that sudden exposure to cold has a more dramatic effect on blood pressure. So all these people that you see diving into icy cold lakes like Wim Hof, you know, I think they maybe have to be a little careful if they have cardiovascular risk factors. When we exercise, if our core body temperature drops by a couple of degrees, then our max heart rate is typically reduced by 10 to 30 beats per minute. And we also see a decrease in VO2 max, which is probably mostly due to the heart rate changes that occur. Our cardiac output actually doesn't change a whole lot, and that's even though the heart rate is down because there's an increase in central blood volume, increased ventricular stretching, increased cardiac, increased stroke volume. That actually, those two effects tend to negate each other, and we see that cardiac output actually changes very little. Decreased peripheral blood flow, as we know, occurs, and this causes decreased blood flow to our muscles, and that may be why we see reduced power output, such as I described earlier in the double pole study, where skiers are unable to produce as much power output when they double pole in cold weather. In terms of long-term cardiovascular effects, well, I'm often asked by my patients about atrial fibrillation. It seems like there was something in the press a few years ago about skiers being more prone to developing atrial fibrillation. Well, this was a great little study done, or a great big study, in fact, done in 2019 in Sweden, and they had a huge number of subjects in this study, 208,000, and these were all Swedish skiers who competed in the Vasaloppet over about 10 years. And the Vasaloppet, if you don't know, it's the world's biggest cross-country ski race, and the longest event is 90 kilometers. So this is a huge undertaking. So essentially, what they showed when these skiers who finished the Vasaloppet were interviewed was that the female skiers had a lower incidence of atrial fibrillation and stroke than the non-skiing population. The male skiers actually had a similar incidence of atrial fibrillation compared to the general population, but they had a lower incidence of stroke. And the most competitive skiers seem to have the highest rates of atrial fibrillation. Having said that, if you had atrial fibrillation, then you did have a lower incidence of stroke, lower mortality compared to the non-skiers who were fibrillating. So, I think the bottom line here is that, yeah, sure, there is more atrial fibrillation. There's a higher incidence of atrial fibrillation when we exercise in the cold, but exercise should not be avoided. And again, probably better not to be a super fast skier, as they seem to have more problems. So to summarize, respiratory complaints are very common in the winter athlete. Don't rely on symptoms to diagnose EIB or asthma. Do objective tests when you have patients that you think have this condition. If pure EIB is confirmed, then the guidelines would tend to suggest using beta agonists first line, but also leukotriene receptor antagonists are helpful, and some of the other inhalers also have roles. The best test seems to be an exercise challenge or the EVH test if you have access to it. I would advise most athletes, most recreational athletes, to limit their outdoor exercise in really cold temperatures, less than -20, and certainly don't run intervals in the cold. If you want to exercise outside, then make sure you get in a good low intensity warm up, start slow. If you're interested in the HME devices, they are available online. They're pretty, the Lung Plus is the one that's most commonly used. It's about $50 online. You can order it from the US. And I think particularly if you have patients with asthma or EIB who want to go skiing in the real cold conditions, that might be a consideration. If you have pre-existing cardiovascular risk factors, then be aware that cold does increase your risk. And recreational skiers do have some additional cardiovascular risk and a high incidence of respiratory symptoms, but these risks are small and are likely offset by the benefits of the exercise itself. So please keep your patients out there exercising. Lastly, I just throw up this slide here. Please be aware of WADA guidelines if you're treating elite athletes. The website Global DRO is a great resource, and you can look up pretty much any drug on there and figure out if it's on the banned list, and it's updated regularly. It's a great resource. I'm on there all the time. And that is everything I have to say. That's where you can find me on social media.
Sweet. Thanks, Andy. That was an awesome talk. You prompted a lot of... Yeah, I know. It's like motor mouth.
Yeah.
Yeah, that's a well-deserved drink in that paper cup. Yes. All right, so I've got a bunch of questions here. Eileen Bridges said, "It's amazing that I can backcountry ski in the woods at -20 and sweat, yet run on an open road in the wind at -10 and freeze. How much does the feels like temperature affect performance?"
Yeah, good question, and I think it certainly does. And if we think back to that Boston Marathon, that 2018 Boston Marathon, the actual ambient air temperature was well above freezing, but it was windy and it was wet, and it made it feel like -6. And we certainly saw significant performance decreases with that wind chill. So yeah, I think there's no doubt that that wind chill certainly can play a big part. And the other piece is that really, when we think about overall performance, there's lots of things that go into that. And if you are cold and miserable and you're running into a headwind, I think there's no doubt that plays on the psyche and will have negative effects for sure. So I think it, is it just how cold it feels, or is it due to other factors? I think it's probably a combination of things.
And sort of a follow-up question along the same lines, Alana Tobe says, is it minus 20 actual temp or feels like wind chill minus 20 as the general cutoff for outdoor training?
Yeah, so feels like minus 20 is what is typically used by, so FIS, who regulate all the cross-country ski races, and the International Biathlon Union, they use minus 20, and they use a feel of minus 20 as their cutoff. So if at any point on the course it feels like minus 20 with the wind chill, and there are charts, you can look this stuff up. If you can look up the what the wind chill will be, but if it feels like minus 20, then they cancel or postpone the race. So yeah, I think it feels like minus 20 would be my sort of my kind of cutoff.
Yeah, mine's about minus 10.
Yeah. Depends how complicated you are.
Yeah, exactly. Okay, so somebody asked, any issues with getting TUEs for salbutamol or other treatments for EIB, as it is technically not the same as asthma? Does diagnosis have to be confirmed by test or certain specialists for purpose of exemption? And the esteemed Alan Verneck popped in and said, salbutamol, formoterol, and salmeterol are not prohibited when taken by inhalation at therapeutic dosages. Other beta-2 agonists require TUEs, which includes specialist evaluation and PFTs. Inhaled glucocorticoids are not prohibited. So
yeah, yeah. So I mean, in terms of issues getting TUEs, I think so long as you have an objective test, and the rules change each year, and in fact, you don't need a TUE for those things at present. Yeah. Okay. There are some of the products, and that's where the global DRO is a really helpful resource, because you just type in what you're prescribing, and it'll tell you whether it's banned, and some substances are banned in competition only and can be used in training. My understanding with the inhaled with beta-2 agonists is that the cutoffs are all to do with urinary concentrations, and that slide that I put up at the end there about the Norwegians who got into trouble, they were nebulizing high doses of salbutamol, and Sundby, the guy who had a picture of who was a top level cross country skier, received a sanction, and he had a hugely elevated urinary salbutamol level, which would have been impossible to get. He could have used an entire inhaler in one go, and he wouldn't have got close to that. So we think he was either injecting it or they were using nebulizers. So yeah.
Or he was using his puffer and spraying it directly into the urine bottle.
Yeah, maybe.
And Alan said, and now Volanterol. So good reason to check every year. Good talk. Good advice, Andy. So Yvonne Kaiser asked, are inhaled chromoglycolates still available in Canada?
Good question. I actually don't know that, because I rarely prescribe them. I have prescribed them in the past. The one that I prescribed is called Intal. So I actually don't know.
Good
question. Maybe you can tell me. Them. Yeah, maybe somebody can tell me. I actually don't know if it's available still.
Yeah, I don't know. Okay, there's one other.
Yeah, sorry, I was prescribed Intal. Yeah.
When you were a kid?
Yeah, when I was a kid, I was on Intel. Yeah.
Oh, wow.
Anyway.
Okay, there's a question I'll let you answer in the Q&A from Roger Hobden, but I think we're going to switch over to Patrick Fredette, who's going to speak to us about hypothermia and frostbite. Just a little bit about Dr. Fredette. He's a CHASM member. And by the way, thanks, Andy. That was awesome.
Yeah.
Okay, so Patrick is a CHASM member and in the Diploma of Sport Medicine since 1995. He has a rural family practice in Manitoba, does medicine, and he's also an associate professor at the University of Manitoba Bilingual Stream for Family Medicine Residency. And he's presently the chair of the Canadian Concussion Collaboration. and he's been affiliated with Canada Soccer National Team, Men's Alpine National Team, and he's a World Triathlon medical delegate. And he has had frostbite several times, so personal experience. And he promises to show us pictures of his own war wounds. And thank goodness he still has all of his toes. So Patrick, thank you once again for doing this talk, and you have the floor.
Well, thank you very much. It's nice to be here, and great talk that we just to follow up on, and a lot of great information there. So I'm going to try to talk to you about this hypothermia and frostbite. And so first of all, my disclosures, I'd have to say as well, I'm from Manitoba, and I'm from rural Manitoba. So I think that's one of the reasons they asked me to do this talk, is they kind of presuming I know what cold is. My conflicts of interest are, I love winter. And a claim to fame is we're a family of 4 CHASM members. So my son, my daughter, my wife, and myself, we're all CHASM members. So we're kind of proud of that. It's beautiful if you've never seen sundogs. So sundogs are this incredible phenomenon that happen in winter when it's extremely cold, where you actually see 3 suns in the sky. So if you've never seen that, come to Manitoba. We have beautiful northern lights. We have 38 species of mosquitoes. Luckily, they're not always there in the winter, but they have little fur jackets, and some of them are fairly big and they can carry you away. This is a beautiful summer day in Manitoba where people are jogging and other people are washing their car. So this is what we see on a common basis. This is a summer day with the Bombers and with the fans, and they're so loyal, and you can see how happy they are to be sharing a beautiful summer day again in Manitoba. Last but not least is we have a lot of deep snow in areas, and we have these beautiful furry little creatures up north that people just want to reach out and hug. But like hypothermia, you have to respect it because it can definitely kill you. And that leads us into our talk here. So the objectives I wanted to go over is just talking about hypothermia and briefly on frostbite, prevention, recognizing and assessing it and treating it, and advice for our athletes, our endurance athletes, but advice for our common patients that are going to be asking to do endurance events or getting out in the winter. And there's a lot of good recommendations there. The sources I used were basically, I did a bunch of literature researches, up to date, some sport performance bulletins and various other magazines, but specifically I also used Professor Popsicle. So if you're not familiar with who Professor Popsicle is from Manitoba, I'll start with this question, this little poll question here. So if you fall in ice water with your clothes on, how long before you're hypothermic? 5 to 10 minutes, 10 to 20 minutes, 20 to 30 minutes, or over 30 minutes? So while you're answering that, Professor Popsicle did studies in hypothermia and cold water immersion in Manitoba. He coined the 1-10-1 principle of when you fall into cold water, and we'll talk about that. So we're kind of getting there. So 5 to 10 minutes. So I'll get to my my answer. Can I go to the next slide as we keep chugging this in? And maybe you can, so we're getting into the 63% in the 5 to 10 minutes. So the answer is actually, most of us get it wrong. It's 30 minutes or more before you become hypothermic. And almost 3/4 of respondents thinks it's 10 minutes or less. So you can see that even by our CHASM members that not many of us think it's more than 30 minutes before we're going to get hypothermic. Just going to go to my next slide here. Okay, so Professor Popsicle, this is Dr. Giesbrecht was, I'll just get the table off my screen. So thanks to Dr. Gordon Giesbrecht, who coined the 1-10-1 principles that when you fall in the water, basically you have 1 minute to control your breathing. And then you'll have about 10 minutes of movement that is actually coordinated. And then you'll die or become unconscious in an hour. So those stats are pretty drastic, but you only start becoming hypothermic in the 30-minute range. So that's when it really sets in. So what is hypothermia? Well, hypothermia is a core temperature that's less than 35 degrees. And basically that's it. That's what hypothermia is. So anything, then you get degrees of it, of moderate, mild, and severe, depending how your temperature drops. And you'll get different symptoms that develop. Your mental status will change, shivering, and all these things will kick in as you start compensating for your hypothermia. And when you're in the gray zone of sort of that 35 to 37 range, a lot of factors will kick into keeping you alive, which is a good thing. Your body is really smart. This is a cascade of the pathophysiology, and it looks fairly complex. And we covered a lot of this in the last talk, but basically heart, brain, and airways are the ones that are going to be mostly affected. And the largest organ that's not mentioned on here is your skin. And what's happening through this whole process is as we compensate, your body doesn't want to lose heat. So it doesn't, you get a lot of vasoconstriction in the periphery, and you're going to start generating heat voluntarily when you exercise. So when you're an elite athlete, you don't know, you're generating a lot of heat. But when you're not generating a lot of heat, you got to do it involuntarily. And as your body temperature drops, you start shivering. And basically, once these compensatory features start failing on you, your body temperature, core temperature starts to drop. So we try to maintain our temperature probably around 36.4, and we'll shunt away from the periphery. And it's quite interesting how we'll create this layer of insulation of poor blood flow on the outside to preserve our organs and our core to keep us alive. Now, this is some clinical manifestation of hypothermia, and it affects every system that gets cold, from your neurological, cardiovascular, respiratory, you name it. As it gets cold, it functions less. Our body is made to function at 36.4, 37 degrees. Anything less than that, you start shutting it down and it doesn't work as well. So name an organ and cool it off, and you're going to start having poor performance in that area. So this table is available and up to date, and it gives us a good summary of what's going on at that point. This is just a diagram showing us exercise in the cold, how the blue part just talks about, your exercise and work depends mostly on how you're going to maintain your warm body. And Dr. Reed was really talking, well, as your temperature drops a little bit, you just don't function as well and you don't perform as well. So preventing that local cold injury like frostbite and maintaining your warm temperature is key to maintaining your performance. Now, this is a fantastic table that I got from Professor Popsicle. It just shows you as your physical ability, you go from 37 to 36 degrees and your physical ability starts to drop already. Your brain will maintain itself till around 33 degrees and then it really quickly drops off. And your shivering will pick up right away. And when you hit 32, it starts shutting down. So you can see that between 35 and 32, you're getting into a dangerous zone. Below 32, you're in big time trouble. And then you get unconscious, and then all the risk to the heart, severe risk to the heart, really kick in at those lower temperatures. And there's this beautiful sentence of you stumble, mumble, grumble, and fumble. And that's what happens to you in those very early stages. You stumble, you trip on your feet, you're not as coordinated, you mumble, and those are early signs that you're getting into hypothermia, and you must get out of that. The causes of hypothermia are mostly not maintaining heat and not insulating it properly. So you can see from increased heat losses, there's a lot of causes, from environmental exposure to skin disorders to alcohol to cold infusions, etc. Decreased heat production will happen with hypothyroidism, etc., hypoglycemia and neurological deficiencies. You can have impaired regulation based on central nervous problems, Parkinson's. You can see all these factors play so importantly to, someone's going to be hypothermic there in one of those pictures. I like that on the screen. So but these causes of hypothermia are, they're really important, and you got to keep them in mind with that. But the bottom line is exposure. So once you start having your prolonged exposure, then you start having some difficulties, and that's that heat loss versus heat generation ratio that's going to get you more into that hypothermia. And this will lead to injury of all tissues from the outside going in. And that's basically a really good reminder of what hypothermia is. Now, you can get conditions like frostbite without hypothermia at all, because what you're just doing is massively cooling tissues on the outside and injuring them. But yes, if you're hypothermic, you are at risk of frostbite. And you can see this person's cheekbones here have been attained. You're shunting away from the periphery. Your tissue freezes per layer from outside to inside, and water crystallizes, and that damages tissues at that point. And you'll go from that red to the white to the waxy color, swelling, and that progresses to deeper tissues. And especially it can be painful when it comes with thawing, because the nerve endings are right under there. And that'll occur in any ambient temperature that's below 0 degrees. It can occur above 0 degrees if there's a lot of wind and water factors, which we talked a little bit briefly before this talk. And also direct contact. You know, you put an ice cube on your cheek long enough, you can get frostbite even though it's 30 degrees outside. So that can lead to loss of digits, and it can lead to your toes. So be very mindful of that. There are also some non-freezing injuries that you're going to come across. And these are usually going to happen in your 0 to 17 degree range when your feet are wet, prolonged, and moist and trapped. And, you know, you heard of trench foot with soldiers, but this is an example of a mountain biker or a road biker who was out 8 hours. You know, he got trench foot, his socks were soaked, took off his socks, and voila, he's got dishpan feet. And that's what they look like. And that can be serious, and that can happen in 0 to 17 degrees. And though this is fully reversible, if you don't take care of it, you can break the skin, get infections, and have significant problems with your feet. There's another form called chilblains, and these are a type of inflammatory response before you start getting too much damage. And you can get a rash, you can get some redness. These are also reversible, but they can damage when you break the skin in these prolonged events. You know, you're rubbing in your socks, the skin is going to break down and you can get infection. So you really have to be wary and on top of these things in long expeditions. This thermal scan I just love because you can see how as you start shunting away how blue the fingertips become. And it doesn't take huge temperature drops. And people can get significant damage to their hands with a very short period of time. So just be mindful that our digits are the first things to go as we vasoconstrict. And you can see that on that thermal scan there. So it's prevention of the hypothermia and frostbite. And how do we do that? Well, we're seeing a huge increase in recreational sports and endurance events. You know, not just our elite cross-country skiers that are doing 90 kilometers, but we're getting people going out there and hiking and snowshoeing and doing all types of events. And some of these people are elite, and some of these are fantastic athletes, but yet they still get injured. And accidental hypothermia is a big problem. And surprisingly, as you start getting events where people aren't prepared, the number of search and rescues has gone up quite a bit in the world because of these events. And when we look at studies of this, surprisingly, there aren't that many great studies looking at it. This study here of accidental hypothermia was in 2018, and it looked at search and rescue. It looked at all the Nordic events. It looked at hiking, trekking, and it's a massive study. And what it found that it's not related to the sport or the temperature that you get hypothermia, it's preparedness and accidents. And that's why they call it accidental hypothermia. And that's why we have to prepare. So this study was quite good, and it had a lot of good data on it. So what does it come down to? So unless you're generating enough heat and insulating it, your body's going to cool down. Water is a really bad insulator. It'll draw heat away from your body 25 times more than air. So stay dry. That's the first key feature. Wind, and we talked about it, it will pull the temperature out of your body. So there's no such thing as cold. It's just absence of heat when you think about it clearly. And you might have lived this if you're mountain biking or if it's cold weather and if you actually do sport like fat tire or stuff like that, and you get a flat or you got to get your phone out and you take your mitten off and it gets exposed to the cold air. It doesn't take long and that hand is frozen and it doesn't warm up well. And you can be in trouble at that point. And it's really hard to bike if you have two hands in your armpits to do that. So the wind chill factor we talked briefly about. So I thought I'd bring out this table, Andy, that you were talking about. And this table really shows how you could be in a nice day of, I'll call it minus 15 in Manitoba. And that's indoors, no, outdoors at minus 15. And then it's beautiful and sunny and you're skiing along, cross-country skiing. And then the sun goes down just below the horizon, below the trees, a little bit of wind, and boom, minus 27. You're in big time trouble if you haven't planned for that and you don't have the right layers. If you fall down and you're wet, you're going to be in trouble. So really be mindful of the air temperature of what's going to happen there. Doctor, we often have to modify events, and you were talking about in cross-country skiing, but in swimming is one of them in triathlon, that we have to modify events based on the air temperature and the water temperature. It's nice to have a wetsuit, but when the air and wind ratio is with the water temperature, we have to shorten events, and at times we even cancel events and just make them into a run bike run event because of the risk towards the athletes at that point. Dr. Steve Keeler had given us a talk from Swim Canada on open water risks and hypothermia. I think it was last year or the year before, and that was really a good talk. So there's a condition also called hiker's hypothermia, and this is a really good condition to know about, and some of you might have seen athletes have it. Hiker's hypothermia is you're out in the cold, you're competing at a high level for long periods of time with a high level of exertion, and then you get fatigued, and then they get hypothermic. And it's not for the same reasons we think. Now they have impaired vasoconstriction on the periphery, and they don't shiver. So they're so vasodilated in the periphery, when they get tired, they don't start shutting down to preserve their core. And they don't shiver because they've burnt out their metabolic drive from all the glycogen. So these athletes or performance athletes or even hikers can be in big trouble with that. So be aware of it, that it's a condition that does exist, this hiker's hypothermia. So these are treatment tips for people that are starting to get very cold and might be getting into early hypothermia. We need to recognize these, and we need to see these in your partner. So for one thing, you want to prepare and prevent. And you want to recognize the shivering, because that's the first sign that you're going to see. And as soon as they're stumbling, mumbling, fumbling, you got to get them out of that environment right away. It's not a time to say, well, we just have half an hour left. We need to get out of that environment. So we need to remove from the cold, get the wet garments off, warm garments on, blankets, hydrate, preferably warm fluids, but hydrate, consume calories. That's really important. And don't rub those extremities, because it can break and damage those tissues. It can injure them. So, and just caution with hot showers. So if we're feeling cold from a nice ski day and we jump in the hot tub, that's fine. But if we're actually starting to be hypothermic and we jump in a hot tub, that can be dangerous, because we can get some paradoxical events cardiovascularly, and we can all of a sudden drop our blood pressure, and that could be dangerous in a hot tub. So just be mindful of that. When we get more severe, we need hospital care. When you're getting to 34, 33, and I work in the emergency department, we see these things, people coming in. There's an ABC, that's the priority, ABC. You want to continue your passive external rewarming. And that's basically a warm room, a warm blanket, get the cold and wet clothes off. Active external rewarming is your hot water bottles in the armpit and the groin area. And if they're conscious, you can get them something to drink. But otherwise, you're getting into active internal rewarming, which are warmed IVs, warmed O2, which is rare in a primary care setting. You want to get that in tertiary cares. And then IVs that are warmed up. You can even flush the bladder with warm fluids. And those will all be helpful things to get the core temperature. And obviously, in a tertiary care center, we'll try to get people through extracorporeal rewarming. Not exactly something we have in a rural town. So this is a great table. It's available to you. It looks at the cycles of what's happening. And this one I would really refer you, everyone to look at. You look at the consciousness loop, and through cold stress, mild hypothermia, moderate, and you're going to stay conscious until you get into severe hypothermia. Yet your movement is going to start changing when you're cold, even before you're hypothermic. So that's a key feature. Shivering starts right away. And alert, by the time you're not alert, you're in big time trouble. So this is a table that really summarizes it well. So here are a few practical recommendations for your athletes and for your patients. So first of all, prepare. Okay, that's the number one thing. Avoid training by yourself. If you're having prolonged sessions or remote areas, always have a buddy. Be aware of each other with your stumble, mumble, fumble, and grumble and shivering. Know about it. Think of the worst case scenario that can happen and prepare for it. Well, what happens if I'm skiing and I break my leg? What's going to happen? Well, that's good to think about it. What do I have as an option at that point? So prepare in advance. Really consider the rain, the wind, and the sudden drops in temperature. So look at your app for your temperature and know what's happening if the wind picks up. Share your plan with somebody so that they know where you are. Use your iPhone share location. That's a great tool. And iPhones are fantastic when they're not wet and they're not cold. So you know that, so keep your phone dry, keep it warm, and have a backup battery, because an iPhone is useless when you pull it out and it's wet and cold and you're in trouble. Plan for shelter in some longer trips that you're doing. If you're doing a 3-4 hour hike, know where the shelters are, that you have wood stoves or anything in there, because that could save your life at that point, especially when it's minus 15 and up. So I'm talking about cold weather here and risk of hypothermia. Uh, Headlamps, reflective clothes if it gets dark, those are just things to think about. Heat sources if you really need to, and a backpack that can have some of that stuff on these longer expeditions. Be aware of your personal risks. Stay within your limits. You know, you look at these two guys and you kind of go, oh my God, you know, what are their risks? This guy's flying on the carpet and he's going, I don't think I should have done this. And the other guy's right on the edge of a precipice. So be aware of your personal risks and know what your abilities are. Because if you don't, you know, you want to have your proper clothing. And we talk about layers, and but proper clothing, you don't have to be multiple layers. The Inuit use one layer and they often have nothing else under their layer and they stay warm. But we have a tendency of wanting to wick that wet away. So that's why we use multiple layers, and layers that you can bring with you that you add on or take off. So it's a great combination. So proper clothing, cotton holds the moisture and it's really cold, so cotton's not a good choice. Merino wool is fantastic. Wool is fantastic. Those are clothes that really keep you warm. The new materials are excellent. Think about a shell on the outside, the extra sweater, layers you can take off. Those are really important at that point. Hot shots can save your life. So hot shots for your fingers and your toes, those can be really, really convenient to know when and how to use those. One of the things that I find is protecting your skin. Use sunscreen, because you're going to be bouncing those UVs off the snow, and you're going to burn your skin if you're not used to it. Even if it's minus 30 outside, you're going to burn your skin. And be mindful of frostbite. So when we got our frosty cloth on our face and the ice builds up, some of you might have lived frostbite right along where the ice is, and it just starts burning your skin at that point. Your eyes are the same thing. You want to protect UV sunglasses, and you want to protect from the cold, because you can get freezing of your eyeballs. That can happen in cold temperatures. You can get your corneas that freeze. It has happened. It's documented. And I know many people that have had it. So it's possible. And also burning of your eyes, you know, getting sunburn right on the surface of your eyeballs. We see those in the emerge, people coming in and they've got like welder's flash from the cold, from the reflective. Nutrition is really important. Make sure that you're getting even a good protein load before your event, and then bring carbs along, because you're going to burn a lot more carbs during these events when you're cold. You're going to burn 5 to 6 times more carbs than usual in a cold event, and 2 times more fat. So just be aware of your nutrition factor for yourself. One of the things that's really important is hydrate. So that's really, really important, because you're not going to feel thirsty a lot of the time. You're breathing in this dry air. You're pulling moisture away from your lungs. You're not noticing you're getting thirsty. You're going to urinate more because you're shunting away from the periphery, and you're going to get this cold-induced diuresis where you get this fluid load to your kidneys and you're going to pee it out. So hydrate really well. Just don't eat the yellow snow. There's a big variability in our body types. And so know your adaptability, know how your body does in the cold. So, and you can adapt this. You can train your capacity to tolerate the cold, believe it or not. And so if you're a person who sweats a lot, if you know you've had previous hypothermia, if you're really skinny, just know and prepare that way. Because you can see in this picture, there's a huge variability in a guy, doing this in his shorts, and the other person it's plus 30 and they're still cold. And there's a difference in gender also. Women have a difference in their surface to total mass ratio difference. So women are often more cold than men. And there's a big fat variability in all our bodies. And I can say this as a personal event. We were in Australia and I did this swim event. It was 3 kilometers. The water was about 17 degrees and there was no wetsuits allowed. So, okay, so I'm kind of standing on the shoreline getting ready, and I look around and I go, I'm the only thin person here. And most people there were well insulated. And I realized, I think I'm in trouble. And one of the Aussie guys came up to me and he gave me a jar of Vaseline and says, hey, Mike, you better grease up or your nards will be in your throat. So I took that as really, really good advice to make sure you protect your skin before. So remember, there's no such thing as bad weather. There's only bad clothing. So get the good layers going for yourself. And I want to do a couple myth busters here. Okay, so Helen, you can help me with this. So myth number 1, can you get cold? No, when you get cold, can you catch a cold? Is that true or false? All right, people are just cranking that in really quickly. So the answer is a combination. One, it is true. So first of all, it's true is that when we're exposed to cold, there is an immunity change. You're going to get a little bit more suppressor macrophages and modified cortisol levels in your body. So you could temporarily have a decrease in immunity. More commonly, we know it's viruses, so you have to be in contact with people. So it's not the cold weather that's going to give you viruses, it's indoors. So it's a kind of a yes and no to both answers. And I just thought we'd share that first myth. The second myth I want to go through is myth number 2. You lose most of your body heat from your head. Is that true or false? I love watching the lines. They're sort of like jostling 46, 45% going on. So we're about 50-50 on here in our answers. And that's been pretty well debunked now. The answer is false. So we don't lose most of our heat from our head. We do lose heat from our head like we would if we exposed our butt. It's basically total surface that you're looking at, and the head is not a bigger surface than the same amount of surface you're exposing elsewhere. So it's no, but wear a toque anyways, and we do feel better once we have that toque on our head. Myth number 3, drinking alcohol warms you up. Is that true or false? Boom, 100%. I love that. Everyone's pretty good at that one. So the answer is false. We do feel warm, when we drink alcohol, we feel warmer, but it's false for many reasons. For one thing, it impairs the shivering reflex. So if you're not shivering, you're not going to generate your heat, and at the same time, it's vasodilates in the periphery, so you're going to lose more heat. And almost as important is impaired judgment. So when we drink too much and we have this impaired judgment, we end up doing silly things, but it's fun. Myth number 4, you should not eat snow to rehydrate. Well, especially yellow snow, but you should not eat snow to rehydrate. Is that true or false? And that's a fun one. And I had a fun time looking that one up and sort of reviewing it. So I'll just start by saying the Inu, they eat lots of snow to hydrate themselves. So that should give you a tip on the answer. So the answer is false. You can eat snow. Whoa, I don't want to show that one yet. So true or false is that if you eat snow, the importance of hydrating yourself outweighs the warming up capacity. So it's way more important to hydrate than the little bit of temperature you're going to lose by swallowing the cold. So the 1 calorie per gram of water that you're going to cool off is really negligible relative to the importance of hydration. So there we go. Oh, sorry, that was my talk, and I hope happy icicles to everyone, and I'll entertain a couple questions. I think, Rich, you're still on the old mute. There you go.
Yeah. Sorry, my daughter was like strangling me with I just got in from freezing downhill skiing and put her hands down my back.
Oh, love it.
So I'm the first case of scapular frostbite.
From thermal hands. That hurt. You should have that thermal scan on his hands.
Yeah, exactly. All right. So thanks for that. I was quite surprised by the alcohol doesn't warm you up factor. Like I was,
you feel
just,
warm.
Yeah, it's got that like a little wine skin thing, and
good.
Okay, so a couple of questions in here. So Eileen says, at triathlon races, we have pulled people out of the water with unrecordable rectal temperatures. When do you send to advanced facilities versus passive rewarming and watch and wait? We send with, she said, we send any with ECG changes and watch without ECG changes as a threshold.
Right. Well, it's good. Like specifically in triathlon, you can have a risk of hypothermia, and you're also, you get the extreme. So I think start passively rewarming people, get them out of their wet clothes and start rewarming them and keep taking the temperature. More importantly is when we're rewarming people is you want to go slowly. and you want to make sure you're following them cardiovascularly. So it's always ABCs, and start rewarming the person with passive external and active internal. And if when you finally get a core temperature, for one thing, most people have the wrong thermometer. So if you're going to be doing hypothermic core temperatures, you need a hypothermic thermometer. If you need one that goes to 30 degrees. So if your thermometer reads normal temperature and you go to take it and it's a rectal thermometer and the temperature is 33, it won't read properly. So one of the problems we're finding is make sure you have the right hypothermic rectal thermometer. That's key. And then passively rewarm them. If you can do cardiac monitoring, fantastic. And if you're noticing changes, I would get them out. Get them out sooner than later. Don't stay in play. Don't take a chance.
That's true. I thought it's nice to see a fellow sports medicine physician that is equally as passionate about rectal thermometers as I am.
I won't ask what you do with them, but that's all cool, Rick. That's whatever's your passion there, buddy.
No. Hey,
Oh,
it's Iron
okay,
Man. It's
okay. Okay, yeah, got it.
Yeah. All right. So Andy had a question over here in the chat. It says, I see cross-country skiers with KT tape plastered all over their faces. Will that prevent frostbite?
I don't have as much experience in that, so that could be a question for Andy. Andy, if you, because I could give it a go. I have a theory, but I'd rather maybe you see what you think at that point.
Andy asked the question.
Oh, Andy did. Okay, so cool. So, well, my thought is okay. My personal experience is if I have a protective layer on my face, even Vaseline, it makes a huge difference. You just don't get the frostbite because you got an insulation layer there. So that K-tape definitely, I think, would make a difference. If the K-tape gets wet and it starts freezing, then you're going to have a nice burn mark the size of the K-tape.
So it'd be almost better just to use the Vaseline.
Vaseline is a good one, or just have a good cloth that covers you and breathe through it. So that could, Robin, did you have any ideas on that personally with stuff that you go through?
Good point. In cross-country skiing, the big one was Dermatone that we used to always use. And I would still use that. This K-tape stuff, maybe it works great, but it's damn expensive compared to a tin of Dermatone or Vaseline.
And it looks cool. It looks cool.
Yeah. You know what looks really cool is when you get the hot shots for your hand and you tape it to your face.
Oh, the big pouches.
You stand out in a crowd there.
I'm a big fan of hot shots.
Yeah, me too. Okay, so anonymous attendee asks, would you please comment on the above 30 and under 30 reheat techniques, peripheral versus central? I'm gathering that's not the above 30-year-old and under 30-year-old. Also, follow up on ECG with a shivering patient. I could not read the ECG lines at all.
Right. ... So for the ECG, if you can't read it, you can't interpret it. There's some basic tricks that you can learn. You can talk to a cardiologist about reading an EKG that has a lot of interference on it. You can still make out things with it. So you can still see the major waves and you can answer that. So, but if you can't read the EKG and you're not sure, then you have to send them out. The above 30, I mean, you shouldn't have anybody that is below 30. That would be like just horrible because those people needed to be in a tertiary care center. That is really serious stuff. And I talk 34 is starting to get serious. 33, we're in big trouble. So when we have patients coming in, they've been outdoors, trapped, snowmobile, and we have them in the emerge and they're at 33 degrees. We start warming, but we get them into a tertiary care center because they're at high risk at that point, especially if they have a frozen limb or something at that point. If somebody has a frozen hand, like it's hard, that person needs to go out. So you take ABC precautions, you got your IVs going, they need to go out because as soon as this starts reperfusing, their potassium goes up, their cardiac stuff goes up, and the cold fluid goes up. It's very, very dangerous for these people, not just our athletes. So I'd say, the comment on below 30, you start slow, and you go up slowly. And if they need cardiac resuscitation at that point, ACLS, you're doing CPR on these people, but at a very slow rate. You're not giving all the drugs. You're doing the right rate for defibrillation and chest compressions, but you're warming them up until you get them about 32, 34. that's when you can start doing the rest of ACLS. So it's extracorporeal if you can do it, warmed IVs, groin, those areas, bladder flushing. We don't do peritoneal lavage anymore because we'll go extracorporeal at that point. And you can also warmed O2. Warmed O2 is an expensive feature, but it works well going through the lungs. It warms all the blood. It's a direct way of warming the blood by getting that warm O2 in there.
Yeah, you're not dead until you're warm and dead.
Yeah, exactly.
Yeah.
Hopefully it's none of our athletes.
Yeah, hopefully not. Hot shots don't work in high altitude. Somebody just put that up on the chat. Interesting.
Say that again?
Yeah, somebody put on here, hot shots don't work in high altitude.
That is really, I've lived that myself. It's got to be really high altitude. So in the 16th, I mean, you're going to be fine. But if you're getting up into 3,000, 4,000 meters, you don't have enough oxygen to start that combustion feature. And we did an expedition once where we were up high. Hot shots are useless. And we're coming back down where it's warm. And all of a sudden, the feet are steaming and the hands are steaming because the hot shots kick in. So, but they don't work in altitude for sure.
Oh, well. Crazy. Okay, if that's all the questions that's in the question box. So I'd love to take this opportunity to thank the three of you for an amazing series of chats tonight.